So perhaps we'll get started. So hello everybody and welcome to this webinar where we are going to present essentially the results of our study on looking at the ketogenic diet and its effect in epilepsy in infants, namely children under the age of 2 years with epilepsy. That said, we have a programme of several speakers. I'm going to give a bit of an introduction with regard to what is the ketogenic diet and how did we get here. Then Natasha Schuller, research dietitian, is going to give us the results of the study. We then have a patient perspective from Rael, namely a mother of a child who's been on the ketogenic diet. And then Julie Fountain from Matthew's Friends is, Julie Edwards is going to give a bit of a perspective with regard to implications and future directions. And then there'll be time for questions and hopefully we'll provide answers at the end. If you have questions, please type them into the question and answers section. There's a Q&A on the bottom of the screen. If you click on that, you'll be able to type in any question and Lara will direct those towards us, to us at the end. And any questions that we've not been able to answer, you please drop us a line and we'll try and answer them subsequently if we haven't answered them at the time. So with no further ado, we do have video recordings of the lectures, but we're all here. And so I will come in at the end of each talk. So the first talk will be from myself about the history of the ketogenic diet in childhood epilepsy. Thank you.
So it comes to me to actually give you a little bit more information about the ketogenic diet and indeed how we've got to this point in utilisation in childhood epilepsy. The ketogenic diet is a high-fat diet that was designed originally to mimic the effects that starvation has on the body. When we starve, we break down our own body fat and the liver generates ketones that can then be used as an alternative energy source. If we actually use fat as the main intake of our diet, it also gets preferentially used and ketones are generated, just as we might see in starvation. We often think of our normal Western diet as high in fat. However, as you see from these pie charts, 50% of our Western diet is indeed carbohydrate. Along the bottom, you will see different pie charts of different ketogenic diets. The classical form that was originally used was utilising long-chain fat, with a lot of use of dairy products and meat fat, for example, 90% of the diet being long-chain fat and a very small amount, namely only 4%, being carbohydrate. As I'll tell you later, the medium-chain triglyceride diet came in later. Medium-chain triglycerides or medium-chain fats can generate more ketones per calorie than long-chain fats. So in essence, maybe a little less is required than in a classical diet, but it is still low in carbohydrate. MKD stands for modified ketogenic diet. Many of you may have heard of the Atkins diet, which is low in carbohydrate. But there is unlimited protein, which makes it a little more palatable, but it is still relatively high in fat in proportion. And there is also something called the low glycemic index diet, which is something we used to use in diabetes, where complex sugars are substituted for simple sugars. And if we look at a traditional ketogenic diet, it was often thought to be unpalatable, unruly, unable to do it because it was so bland. And you can see here that if we use traditional fats, you can see it could be considered to be very bland in an older individual. But now there are many, many different recipes, many different individuals and companies producing products that I would challenge anybody to think that this looked unpalatable. So how did it start? The ketogenic, it was in 1910 that an osteopath first reported that he deprived a patient with epilepsy of food and only gave them water for up to 25 days and demonstrated a cure rate for epilepsy of between 50 and 90%. However, this was obviously unsustainable and therefore it was rethought, but it was Wilder in the 1920s who thought maybe we could generate the benefits of fasting if ketonemia was produced or ketones in the blood were produced by another means, and he suggested a high-fat diet. This was utilised over many, many years until about in the late 1930s, phenytoin was introduced, and it was thought that a simple anti-seizure medication would cure all those with epilepsy. And it was used on and off after that, many feeling there were too many side effects, and indeed it was not really palatable. So in the 1970s, it was Huntenlocker who suggested utilising medium chain fat rather than long chain fat because of this the fact that medium chain triglyceride oil was more ketogenic per calorie than long chain fat, and therefore permitted a greater bulk of other foods and made it more palatable. It was still used relatively infrequently until the mid-1990s, when a film producer's son was put on the ketogenic diet as part of the treatment from the Johns Hopkins University's hospitals in Baltimore, and was able to publicise the considerable benefits that he'd seen in his son Charlie in the mid-1990s. And thereafter there was a lot more publicity. He actually produced the film Do No Harm, starring Meryl Streep, and also there was a lot more scientific interest, to the extent that if we look scientifically, the number of publications since this time has increased astronomically and still increasing over time, demonstrating that actually there may be a mechanism, different various mechanisms of action of the ketogenic diet, and that it is indeed useful in the treatment of epilepsy. However, there was still a lot of scepticism for some time, not least because when you're assessing new treatments, they need to be assessed in a particular way in order to be scientifically valid. You can see here that there are different stages to assessments of new treatments. They're going from what we would call the preclinical stage, so before humans, in laboratory and animal studies, then going to safety studies utilising few people, then to dose finding and efficacy and confirmed safety and efficacy, utilising many, many more individuals preferably. And this is where randomised controlled trials are utilised and are the best evidence base. So what is a randomised controlled trial? This is where individuals may be randomised, so selected randomly, usually generated now by a computer, if they fulfil inclusion criteria for a particular trial, to receive one of several interventions, maybe one of two interventions. The intervention we want to try versus the intervention against which it needs to be compared. And randomisation limits the potential for selection bias. We're not going to say this is an individual, this should have a different type of treatment. We're not going to have any control over that. More often than not, a double-blinded trial is what is required. Blinding, namely the individual who's prescribing the treatment and indeed the individual receiving the treatment does not know what treatment that they are on, because this minimises information and investigator bias. And usually in these trials, the precision is determined by a predetermined sample size. We calculate how many individuals are required for each group in order to get statistical significance should a benefit be demonstrated. However, for many years, the trials utilising ketogenic diet were only what we call observational. Namely, there was only individuals who were put on the ketogenic diet that were actually assessed. And therefore, there was a lot of scepticism about whether this diet did in fact have any benefit, particularly in childhood epilepsy. In 2008, we published the first randomised controlled trial of looking at the ketogenic diet in the treatment of childhood epilepsy. We had conducted this trial between 2001 and 2005, and this was a trial involving children between the ages of 2 and 16 with epilepsy that had been resistant to at least 2 anti-seizure medications. And we randomised children as they came to us into either receiving no change in treatment for 3 months or a ketogenic diet. And after 3 months, those that had no change in treatment had the opportunity to go on the ketogenic diet. And what we demonstrated that is over that 3-month period where we had ketogenic diet versus no change in treatment, there was a significant benefit seen, namely a significant reduction in seizures from baseline in the group that were trialled on the ketogenic diet. And if you look at the graph on the right, this was sustained over a 12-month period. What we also looked at is that we randomised not only whether they went on the ketogenic diet or no change in treatment, but when they went on the ketogenic diet, we randomised whether they received a classical diet with long chain fat or a medium chain triglyceride diet. And we could see that there was no significant difference in the comparison between those over 12 months. The reason we chose children between 2 and 16 was not because we felt there was any difference in under 2s, but the fact that we had to administer this diet as an outpatient, and at that time it was considered much easier in the older population. Since this time, of course, there have been more randomised controlled trials, and this is a Cochrane systematic review where they take all the literature, they evaluate it, and they then decide whether collectively there's evidence base for a particular intervention. And this found in the most recent Cochrane review of the ketogenic diet and the epilepsies, 13 randomised controlled trials in 17 publications. This said, not all of them are looking at the effectiveness or the efficacy of the diet. Some of them look at the ways of administering the diet, whether you hospitalise to start with or whether you starve to start with for the first 24 hours. But that side, we now have a whole selection of randomised controlled trials. And there were 4 that actually have a very similar methodology, so actually could be put into what we call a meta-analysis, and demonstrating that actually effectiveness favoured the ketogenic diet over standard of care. However, you can see that across the 13 randomised controlled trials, majority were in fact children, and it's actually children in these 4 trials that were put into the meta-analysis. Of course, we have to look at side effects, and it's not a natural treatment. We have to say that. Yes, we utilise natural products, but there are side effects do occur. And those that have generally been reported in the past are predominantly those to do with the gut, whether it be vomiting, constipation or diarrhea. In a very small number, calcification in the urine, usually in younger population and those that don't drink effectively. And there is evidence that over time growth is slowed, particularly in those that start on it very young, but there is catch up once they come off the diet. And certainly in our trial, we didn't find very specific differences or any side effects that couldn't really be adjusted or alleviated by adjusting the diet itself. When we come to infants, I have to say there has been very little study of treatments for epilepsy in a randomised controlled way. There has been data produced in the most common seizure type we see in the first year of life, namely infantile spasms. But actually when it comes to other epilepsies, there is very little in the way of evidence base, predominantly those pharma-sponsored trials looking at the treatment of drug-resistant focal onset seizures. Certainly there's very little in the way of other randomised controlled trial data. Over the years, there's been evaluation of what role the ketogenic diet may play, particularly in infantile spasms, as I said, the most common seizure type we see in the first year of life. And you can see that there are several studies, not necessarily randomised controlled trials, suggesting there is a benefit whether the standard treatments are utilised or not. And certainly Dressler et al. Most recently reported on a randomised controlled trial in newly diagnosed spasms, so first line treatment, comparing steroids as standard treatment to ketogenic diet, demonstrating remission, as you're aiming for complete remission of seizures in this group, similar to be the same at 28 days, and no significant difference in relapse rate. And even knowing that infants are a more tricky population, guidelines or recommendations for utilisation have been produced. We published these in 2016, led by Ellis van der Lauw, just giving the general information in view that many of these are on liquid diets and indeed ultimately require help with weaning. Colleagues, namely Laura Lyons and Natasha Schuller, looked at the literature to see what evidence base we have with regard to treatment of infants with a ketogenic diet. And although they found a lot of publications suggesting benefit, when it came down to looking at those that could be included in the analysis, those looking solely in infants were only 5 studies, and infants as a part of a wider cohort of children, about 28 studies. And you can see that looking at the meta-analysis, there was a suggestion of benefit. But the overall conclusion from this study was that although ketogenic diet therapy was seen to be safe and tolerable and an effective treatment option for infants with drug-resistant epilepsy, there were few studies focusing on infants, and high-quality evidence was lacking. And therefore, the suggestion from this systematic review was that high-quality randomized controlled trials were needed to confirm the effectiveness, safety and tolerability of dietary treatment in this vulnerable age group. And hence where we are with now reporting on the KIWE trial, the ketogenic diet in infants with epilepsy trial.
So the conclusion to that, I think, is self-apparent. We felt there was a need for the study, the ketogenic diet in infants with epilepsy study. So Natasha is now going to tell us about what we did with that study and indeed the results.
Good evening. My name is Natasha and I'm a Senior Research Fellow at UCL Great Ormond Street Institute of Child Health and a ketogenic dietitian at Great Ormond Street, and I'm delighted to be sharing with you the results of our KIWE study today. So the aim of KIWE, Ketogenic Diet in Infants with Epilepsy study, was to see how effective the ketogenic diet was in reducing the number of seizures, compared to how effective another anti-seizure medicine was in reducing the number of seizures in infants with epilepsy. We also wanted to look at retention, so how many people stayed on both of these treatments, quality of life, and also how these infants developed. And we wanted to see whether certain types of fats played a role in how the ketogenic diet worked. I won't go through the results of all of these aims, but hopefully focus on those that are of most interest to you. So KIWE was a randomized controlled trial. This means that participants were randomly assigned which treatment they would start. And as part of KIWE, 19 sites across the UK were involved. So we included infants who were aged 1 to 24 months at randomization with epilepsy, who continued to have at least 4 seizures a week on average, despite having tried at least 2 anti-seizure medicines. So those who agreed to take part in the study, first of all, just went about their daily lives for either 1 or 2 weeks, depending on how stable they were clinically, apart from recording the number of seizures they had in a seizure diary. Then at the end of this period, they were randomly assigned to start either a classical ketogenic diet or another anti-seizure medicine, in addition to those they were already taking. And you can see how many infants we had in each group on the chart with the N equals. We then followed up all these infants for 8 weeks, and this was the time during which we looked at how many seizures they had as part of our main aim. So this was our intervention period. We then followed all the infants up at various time points after 8 weeks, up until 12 months. So when doing randomized controlled trials, we need to make sure that the people we have in each group are overall similar. Otherwise, if we find something different in one group, we can't really be sure whether our results are because of that difference or because of the effects of, in this case, the diet or anti-seizure medicine. So overall, we did have pretty similar groups, those who are randomized to ketogenic diet and those who are randomized to a further anti-seizure medicine. For example, the average age at which infants were randomized in the study was similar, just over 1 year for both groups. There were more or less an even split between males and females, and they were mostly, as you might expect, white Caucasians. Around 2/3 of infants in both groups had a specific epilepsy syndrome diagnosis. And of those who did have a diagnosis, there were similar syndromes or epilepsy types in both groups. The most common being infantile epileptic spasm syndrome, which was half of those with the diagnosis in both groups. And the next most common was early infantile epileptic encephalopathy, and so on. And the most common types of seizures also fitted with these epilepsy syndromes or types. So spasms was the most common seizure type, followed by focal seizures, and so on. So there were some infants who withdrew from the study before the end of the intervention period, so the 8-week point. This was as expected, and again, this happens in every trial. And as you can see, the proportion of withdrawals was the same in both groups, which is a good thing. And I've put here the main reasons for these individuals withdrawing in both arms. So in the anti-seizure medicine arm, the most common reason for dropping out was because the parents or carers wanted to start the ketogenic diet immediately. Whereas in the ketogenic diet arm, the most common reason was due to a medical decision. So the local clinical team advised them to withdraw. And then second most commonly it was because the family was overwhelmed with it all, and this might have been because other things that were going on in the family. And here's the meaty bit. Now, very positively, we found both the ketogenic diet and the additional anti-seizure medicine to be effective treatment options. So 44% of those on ketogenic diet had at least a 50% reduction in the number of seizures. And 40% of those in the anti-seizure medicine arm had at least 50% reduction in their seizures. 11% on diet were seizure-free, 13% in the anti-seizure medicine arm were seizure-free. And there was no significant difference between the two groups, which is what these numbers in the top right-hand corner show you. However, despite this similarity, we did see a difference in something. So as part of the protocol, within the first 8 weeks, this intervention period, the medical teams weren't meant to change the other anti-seizure medicines that the infants were taking, unless of course there was a real clinical need to do so. Now, half of those in the anti-seizure medicine arm did have changes in their other anti-seizure medicines because they needed to. This was almost always an increase in dose of the medicines they were already taking, or a short course of an additional medicine due to increase in seizures. And compare this to those in the ketogenic diet arm, where only 14% of those needed changes in their current anti-seizure medicines. We also looked at quality of life. This was assessed using the infant and toddler quality of life questionnaire. And I'm presenting here to you the results from the 8-week point, mostly because I think it's easiest to interpret at this point, because all individuals, unless of course they had withdrawn from treatment, were on the treatment that they had been randomly assigned to, so either the ketogenic diet or the anti-seizure medicine. Now, many aspects of quality of life were more favourable in the diet arm, and you can see here on the left-hand side the list of those aspects. We didn't assess the difference between the two groups statistically, but these numbers were on average higher in the diet group. Perception of health, on the other hand, was less favourable in the diet arm, and there are a few items here in the middle that were equal in the two groups. And I'd like to highlight that one of these was impact on parental time, which is perhaps surprising, as one may expect that when administering a ketogenic diet, that may have a negative impact on parental time, but actually this wasn't shown to be the case here. As part of trials, we also have to note down basically everything that happens to the little ones, coughs and colds, that sort of thing. And when these events are serious, so for example, if it causes the individual to perhaps to die, have to go into hospital or stay in hospital for longer, we call it a serious adverse event. The proportion of infants who reported a serious adverse event during the whole study, so this is across 12 months, was pretty similar in both groups, so 43% and 51%. We also looked at side effects from treatment with use of a questionnaire at each time point. And here I've got the average scores at the 8-week point, average of 41 in the ASM arm and 40 in the KD arm. And again, they were very, very similar, which is a positive thing. So the serious adverse events, we also categorised into different types using a standard coding system called MEDRA. And you'll see that overall the types of events, again, were pretty similar in both groups. So the most common group of serious adverse events in the ASM arm and the second most common in the KD arm was nervous system disorders. And this was pretty much always seizures. And then we have infections and infestations, such as respiratory tract infections or infected adenoids, for example. That was the most common group in the KD arm and the second most common in the ASM arm. And in general, the proportions are similar in both groups. The number of reported events overall is higher in the KD arm, but that is because we had more infants in the KD arm on purpose, but overall the proportions are similar. We looked at neurodevelopment at 12 months compared to baseline using the Vineland scales. We didn't find any significant differences between the two groups, although I have to say the numbers we had in each group with fully completed scales were very small. These questionnaires really are very comprehensive and often quite difficult to fill out properly. But despite this, there were some scores that were overall higher in the ketogenic diet arm compared to the anti-seizure medicine arm. So these were communication and socialization, and some that were lower in the ketogenic diet arm, namely motor skills and, to a very small extent, activities of daily living. We did have some challenges along the way in this trial, mostly to do with recruiting participants to take part. It took a lot longer than we anticipated to get the numbers that we needed. COVID aside, which certainly did have an impact, but we found that perhaps families didn't want to take part because they had a lot going on. Many had been recently just diagnosed, for example, and often there was a desire to change treatment immediately, both from the parents but also from the medical teams as well. So either people maybe didn't want to undergo the baseline waiting period, or the medical teams didn't think it was appropriate for little ones to do so, or perhaps to stay on one treatment for 8 weeks. Another reason for families not wanting to take part was because they wanted to start the ketogenic diet immediately or as soon as possible, and they didn't want to risk waiting longer if they were randomised to the anti-seizure medicine arm. Also, completing seizure diary data. This we found was very cumbersome for families, understandably. And in the end, we simplified it, and instead of recording the number of each type of seizures that the little one had, we asked just for the overall number of seizures during the 8-week period, and this did work better for people. So to conclude, we can't from our trial say that the ketogenic diet is more effective than a further anti-seizure medicine in infants with epilepsy. However, what we can say is the diet appears safe to use in this age group and should be considered a treatment option in infants who continue to have seizures after having tried 2 anti-seizure medicines. There were lots of people involved in this trial across the different sites. These are the lead medics at each site, to which we are very grateful for their help in recruiting and gathering data. And also the dietetic teams at said sites, trial managers, statisticians, and many others. Thank you very much.
Thank you, Natasha. So now, before we look perhaps at the future implications of this, we have a parental perspective. We're very grateful to Rael, who is going to, we have a recording as to what her experience of the ketogenic diet has been.
Hi, I'm Ray, and my daughter Ace. I'm here to tell you a bit about her and her journey with the ketogenic diet and her epilepsy. So Ace was born fairly typical little baby. She had a slightly floppy neck, but we were given the all clear and went home, and everything was fine. She developed fairly typically up until about 3 months old, when she had her first partial seizure. She continued to have partial seizures, so the doctors at the time put her on sodium valproate. That didn't really work. I noticed all my friends' babies were starting to get milestones, and she wasn't really getting any. If anything, she was kind of regressing and smiling less and being less interactive and this kind of thing. Until she started having these. I thought it was a startle reflex coming back, but it was like a startle seizure. And we kind of did a little bit of research into that and found out that it might be infantile spasms, which is a very serious condition. So we went straight to the hospital. We were immediately sent to Royal London, where they began high-dose steroid treatment, which is fairly nasty treatment, but justified by the seriousness of the condition. That didn't work. So we just kind of ran through all the next protocols with that particular condition. Vigabatrin, we tried trazepam. We tried lots of different medicines, but nothing was working. She continued spasming. And they all had terrible side effects. She would go from being really angry and hungry to just sleeping, 23 hours of the day. It was a really difficult time. Eventually, we were referred to Great Ormond Street, and they did lots of tests to try and find out what the root cause of the condition might be, her epilepsy. And they put her onto high-dose steroids and Vigabatrin combined, and that worked immediately, which was amazing. I was starting to give up hope by that point. So finally, we got rid of the infantile spasms, and then around about that time, I think she was about 1 at this point, we found out that she had an SCN8A mutation. And because we had that diagnosis, we were able to give her a better suited anticonvulsant, so we switched her to phenytoin, and again that helped, but she was still seizing really regularly, daily, really, and life was pretty tough. It was better. By this point, I'd kind of done a bit of my own research, obviously, and we tried so many medicines. I was kind of excited to try the ketogenic diet, and I think we voiced that to our doctors at Great Ormond Street. And fortunately for us, the KIWE trial was coming up, and they offered us a place, which we obviously jumped to the chance to do that. Fortunately, we were put on the diet side rather than the blind side of the study, so we began the ketogenic diet fairly quickly. That's how we found out about the diet. Yes, we were very excited about it. We were assigned a dietitian. They gave us lots of amazing and helpful printouts with all the different weights of food that we needed to do, and recipe ideas. The dietitian that we signed up with, Marion, was absolutely amazing, really experienced. She had loads of useful tips. When any problems came up, she kind of had solutions or ideas about what to do with them. So things like Ace had really bad constipation when she first started the diet. I mean, it was really bad. This caused her a lot of discomfort, so she was up in the night a lot. I was having to walk around the streets of London in her pram to calm her down. It was really hard. But we got her onto laxatives, and we learned to weigh them out and get them exactly right. So there was a lot of that kind of making lots of adjustments, finding foods that she would eat, she enjoyed. Fortunately, Ace was so young, she was 1, I think, 1 or 2 when she started the diet. So she'd not really known food, and I was still breastfeeding actually, so she's probably about 1. So in terms of eating the food, once we found the kind of tastes that she liked, that was really easy. And I know that is a massive struggle for children, older children who already have an established way of eating. So we were very lucky in that respect. Yeah, she cried a lot. I mean, she cried a lot. It really took a lot of adjusting for her. And I think we wondered that she might have reflux with the high-fat diet. So we also tried adding, what would it be? I can't remember what it's called. and anti-reflux medicine there. So we added that. So there was lots of other medicines that we had to kind of add on to kind of support in this diet change. But eventually we got our rhythm with it. It did take a considerable amount of time, I'd say quite a few months for her to settle down into it, and they were hard, those months. But the results from the diet were phenomenal. We were so lucky. She went from having seizures every day to having no seizures, you know, and going from being completely unresponsive to, you know, seeing things and touching them and kicking them, you know, and it just, that, you know, the pace at which she recovered was more than we could have expected. She started rolling over and lifting up her head and all these kind of exciting things that we hadn't seen yet. So even though it was incredibly tough, you know, no seizures, hitting milestones, it was worth the effort for us, really. Fortunately, I wasn't working, so I was able to really support all the challenges that we faced. So yeah, it was difficult, but worth it. And then once you get the hang of it, it's fine, it just becomes part of life. I just got used to kind of batching meals, so there was always something to put in the microwave. You can eat pretty healthily, like fortunately Ace likes vegetables, so I would put a lot of broccoli, like low carb vegetables, and also a lot of broccoli, spinach, this kind of thing. So actually Ace was eating really, really healthily, and as I say, it was all purees because she couldn't really chew. So that made it easier because all the food was mixed together. She wasn't having to eat the ingredients separately. I can imagine for older kids, if it was like broccoli and I don't know, some cream, they might not want to eat certain bits of it, but for us, pureeing it all together worked really, really well. So that was one of the easier bits for us. Yeah, like I say, it was very easy in that respect for us once we got over the constipation, acid reflux. Team was so supportive. I mean, we had Marion, our dietitian, who's brilliant. I could always call her, you know, she might not respond immediately, but she would respond very quickly. So that was incredible. The epilepsy nurses were always on the end of the phone if there was some emergency. I felt very well supported by the hospital. We had all the contacts we needed, and if we needed to get in touch with the doctor, we would go via the epilepsy nurses, and again, things would get sorted out very quickly. And we had regular kind of checkups at Great Ormond Street as well. Another thing I forgot to mention, I suppose, is we had to test her blood for ketone levels, which again could be something that would be challenging for some children. But again, Ace was so little, I don't think she really noticed because it's kind of a painless procedure. But that could be difficult for some kids, I suppose. I think really for parents, you've got to work out what your unique circumstances are, what your unique pros and cons are. For us, Ace was so unwell, and her, you know, nothing else was really working, so we didn't have many options. And we had the support and the time to dedicate to the challenges of the study. So we were really fortunate, but I'm aware that not everyone has those privileges. Yeah, so that's kind of it, I think, really. I hope this has been helpful, and yeah, as I say, for us, it's been a really positive experience, and I'm so glad Ace had the opportunity because it really changed her life. I don't think she would be where she is now without it. Okay, thank you.
Thank you, Ray, for that insight. Always useful to hear the lived experience of the ketogenic diet and indeed what it was like being on the trial. So now our last talk is from Julie Fountain from Matthew's Friends, who's going to give us a bit of an insight of what they feel may be the implications of this, the results, and indeed future directions. Thank you, Julie.
Hi, thank you to Young Epilepsy for hosting this webinar. and for inviting me to join today. I'm Julie Fountain, CEO of Matthew's Friends Charity, a charity founded in 2004, and we specialise in providing information, training, research and support for the use of medical ketogenic dietary therapies, or keto, in children and adults. So thinking about the implications of the KIWE trial, these are indeed exciting times with the research supporting early use of keto in devastating infancy onset epilepsy and with comparable effectiveness on seizure control to anti-seizure medications. We know the devastating effects of uncontrolled seizures, interrupting development and learning, and ultimately making the epilepsy more difficult to treat in the future. Keto, as we have heard, started early, may for some children reduce seizure burden and the impact of seizure on patients. And it's an option that we wholly support where it is medically appropriate to do so. Arguably, infancy may be the best time to practically implement keto, with formula initially being the main source of nutrition and tastes and preferences not yet established. Choices and control are less of an issue for these infants. And a ketogenic formula is available for bottle feeding, and when weaning onto solids, this could be straight onto keto-friendly foods, such as cheesy celeriac mash, avocado, and other tasty foods. Keto can also be implemented successfully for tube-fed children. And there is ongoing work and research to further support combining breastfeeding with keto, and that's an important consideration for many parents. Ketogenic dietary therapies are not without challenges, and families are already bewildered and scared coping with an epilepsy diagnosis, and there are many considerations to be made. Those early months of life pass by very quickly, and perhaps keto may be considered earlier than it presently is. Currently, after 2 anti-seizure medications have been tried, we know in reality that multiple medications are often failed before keto is considered. What are the potential long-term effects of starting keto, specifically in infancy, i.e. on growth? And will infants need to stay on keto for the usual recommended 2 years? Or if the diet is effective, could this be reviewed and perhaps weaned off earlier? Whilst there are some very effective keto nutritional products available on prescription, very few are available for use in babies. In fact, most are only suitable for over 3-year-olds. And it would be good to see further product development in this area. Where infants are prioritised to start keto, what will be the impact on waiting times for older children? As we know, in some areas, waiting lists can already be lengthy. An increase in services will undoubtedly be necessary, as will more specialised dietitians to work in this area. Managing keto is a team effort, starting with the patient and their family, and working closely with the dietitian, the neurologist, and other members of the medical team that may include a neuropsychologist, specialist nurse, a dietetic assistant, and others. We are so fortunate in the UK to have a network of amazing specialist ketogenic dietitians working in the NHS. And they work effectively together to improve outcomes for patients, as we have seen with the results of this trial. And of course, supported charities to provide practical resources like starter packs and recipes, peer-to-peer forums, chat nights, and listening ears. Matthew's Friends have an online private Facebook support forum. And in preparation for this webinar, I asked our members, who are all parents of children with epilepsy on keto, or they are adults who are prescribed keto, I asked them to share their one word that best describes keto for them. And I'll leave you with this word cloud, as I think it sums up just how impactful keto can be. Thank you.
Thank you, Julie. Some very powerful words. So if I can ask everybody to come back on with video and turn on their mics, and Lara will sort out the questions. Just remember that if you have a question, please type it in the Q&A by clicking on the button at the bottom of the screen, and we'll endeavour to answer your questions. Thank you, Lara.
So the first question we've got is there any suggestion that a keto diet would be good to try for most epilepsies, for example, in late teen onset epilepsies? Helen, I don't know if you want to start.
Sure. There's no real reason why a ketogenic diet shouldn't be effective at whatever age. The limitations probably are with regard to implementation, namely administering the diet. We generally say that we wouldn't use it as first-line treatment because it is a lifestyle change, and therefore in epilepsies that respond promptly to one medication with no side effects, there are one or two that we might utilize it early, but in majority would wait to see whether they really were failing the medication. That said, in older teenagers and adults, it's been very difficult to get the evidence base because there has been a randomized control trial, and it was very difficult to recruit to, not least because for adults to consider the restrictions in the diet was quite difficult. And even when it has been implemented, if a dramatic change hasn't been demonstrated, it is quite a lifestyle change. It is quite limiting, and therefore it's difficult to sustain. If we think about children, once they sort of eat when they're hungry, and if they're not hungry, they stop eating. Many of us adults, particularly me, eat because we like eating, and we don't necessarily stop when we're full. So a restrictive diet can be quite difficult. So no, there's no reason why it shouldn't be effective, but it can be quite difficult and restrictive, and therefore the benefits have to be considerable to continue it.
Fantastic. Thanks, Helen. So we have another question about the implementation of the diet in infancy. So would infant need to be hospitalized to begin the diet, say an infant of, say, 6 months? Natasha, I don't know if you want to start on that one.
Yep, that's fine. So usually we admit those who are aged under 1 to start the diet. This is in the UK, but quite commonly in other countries as well. And this is generally admission for up to 5 days. For those who are between age 1 and 2, it kind of depends on the individual patient and where they're at clinically. If they're less stable at that particular time, then we might consider an inpatient admission, but otherwise we would do it as an outpatient. And again, in the UK centres, at the very least, we tend to do all other non-emergency starts as outpatient initiations.
Fantastic. Thanks, Natasha. There's a couple of questions, and I actually got a couple of questions in the run-up to the webinar about the kind of supports that are available to parents if their infant or child is to start the ketogenic diet. Julie, I know you mentioned some of them, but perhaps you could just expand a little on some of the supports that are available to parents.
Yeah, sure. So initially what we would do is invite a parent or both parents to join our forum. It's a closed forum, it's private. We only have members that are medically managed by a keto team, and there they can ask questions from other parents and other experienced mentors that we have in the team. We've got a wonderful lady, Val, whose own son was on the diet for many years. She will speak to families at any time. I was going to say day or night, not necessarily night, but she's very available. Yeah, so we have that. We have the support of a keto chef who can work with the families to develop foods to the taste of the child. That sometimes that can be a problem. We can support the dietitians in really making the recipes specific to the child. And then there's starter packs and resources, animation videos to share with nurseries and schools. There's a lot of resources that we can offer to help.
And just to add, as Julie said at the beginning, this is in addition to the support that's given by the keto team, who will be there first and foremost and will provide support. But this is support in addition to that.
Yeah, this is specific
for Matthew's friends.
Yes,
yeah.
of course, yeah.
Great, thank you. There are a couple of questions on KVita, a couple of people that have been offered this. Can you tell them anything about this?
Do you want me to start, Natasha? You want?
Yeah, whatever you like.
KVita is a medium chain fat product that was developed when it was shown that a possible mechanism of action of the diet was the fact that medium chain fat with 10 carbon, not 8 carbon, was the predominant one that would actually be beneficial. Our traditional medium chain triglyceride has got mainly C8. This was a product that was C10 with a little bit of C8. This has been utilized in a safety and dose, what we would call a dose finding study in adults and children, and shown to be safe. And it was a product that is given sort of 3 times a day in a certain amount. It's like the consistency, I suppose, of a yogurt, bit more fatty than a yogurt, but the consistency of a yogurt. And it still has to be done in conjunction with a dietitian to make sure calories aren't too high and weight gain is controlled. But that said, in this preliminary study we did, it showed even though we didn't have a baseline of seizures still went down over the 3-month period that we tried it, which was the main aim. Now it is available commercially, and so it can be used by dietitians, although cost can sometimes be prohibitive. But that said, ketogenic diet teams are aware of it, and it can be an alternative. Natasha, do you want to add anything to that?
No, I think that's a great explanation of it. I guess on a practical note, it's strawberry flavour and does taste pretty nice. But again, it's something that, you know, you would have to continue taking. But really the aim, I guess, of the supplement is to provide an alternative to ketogenic diets for those who are, for whatever reason, unable to access a service, or for whatever reason can't, or it's not possible for them to start a ketogenic diet. And as Helen said, that we don't have high quality trial evidence to show effectiveness of the product in controlling seizures and or movement disorder for those with GLUT1 deficiency syndrome. However, we did see some very promising results in our initial sort of safety, tolerability, how do people accept it study. But it's being used fairly widely in clinical practice now, at least in children in the UK. And I think we're going to learn a lot from that, and it certainly seems like a promising option for certain individuals.
Fantastic, thanks, Natasha. Maybe time for one more question, and there is also a couple of comments about the resources you mentioned, Julie, so we'll make sure they're sent out with the webinar recording. But maybe a final question. Given the correlation between epilepsy and autism and the given challenges around food, is there any research on information or support specifically into this?
It's interesting because, you know, when we've done the trials, autistic behaviour hasn't necessarily been a contraindication. It hasn't necessarily meant that the diet is not successful. Sometimes individuals' food preferences can be quite rigid, and you can work around that. I have had children on a muffin 3 times a day, but, you know, and then they move to something else, and their siblings are a bit jealous that they're having a muffin for breakfast. But, you know, yes, when we talk about contraindications to the diet, it's usually behaviours around textures. If textures, you know, children can't tolerate certain textures, that can be quite difficult to administer the diet. There is ongoing research about benefits of a ketogenic diet in autism, although there's no real randomized control trial. And it's quite difficult because, of course, if you give quite a structured diet to an individual, that could also have effect, not necessarily the content of the diet. So we haven't seen that it's contraindicated. We haven't seen that it has adverse effects in that. And of course, if we're helping the epilepsy, we may also be helping other features which parents report, as you heard from Ray's mother. So it's something that needs ongoing research.
Fantastic. Thanks, Helen.
Okay. So I think we have hit the hour. Albeit we had a few technical difficulties at the beginning, and I apologise for that. The recording will be available for all those who've registered. And if there are some key questions, particularly with regard to providing the links to the resources, we can provide that following the webinar as well. So thank you very much to my fellow speakers, and thank you to all of you for attending. I hope it's been useful.
Thank you.